how many people out there are in an environment where either the quality of your care or your hospital's care or your clinical setting is being monitored in some way or another? Okay. How many are still in environments where no quality monitoring is going on? Okay. Just most people have some quality monitoring going on. So this talk is about the best way of monitoring quality. It's also underlying about the best way of making inferences about the truth of what is going on. So I'm going to talk about the options in terms of measuring quality, the limitations of observational studies in terms of observational studies with large administrative databases, adjusted analysis, and before-after studies, and then the way forward. So, say we asked the question, how is your hospital doing with respect to treatment of patients with myocardial infarction? There are two fundamental ways of looking at quality assurance, and that is to look at process measures or to look at outcome measures. Process measures are things like the time it takes from the patient coming in the door to getting their stent inserted, the proportion who receive aspirin, or the proportion who are offered other treatments that may lower their subsequent risk, like statins, clopidogrel, and beta blockers. The outcome, if you were measuring outcome, it would be 30-day mortality. How does hospital A versus hospital B do in 30-day mortality? So one can ask, how does the hospital do in these process measures, or how does the hospital do in terms of the outcome measures? Now at the moment, just off the top, what do you think is preferable for measuring quality assurance? The process measures, door to stent, proportion receiving ASA, other drugs, or the outcome, the 30-day mortality? How many would think a better way is process? Hands up. How many think a better way is outcome? A little bit more on the out. So some process. So the audience is split here. Some think process is better. Some think outcome is better. Rest of this talk is reflecting on the relative merits of the two approaches. So Hospital A, let us say, has a 10% death rate after MI, and Hospital B, 15%. What are the possible explanations? Well, one possible explanation is that B is delivering poorer care, but there is another one. Maybe Hospital B is looking after sicker patients. They're older, they have bigger infarcts, and more comorbidity. Is there any way of sorting out these two alternative explanations? Hospital B has sicker patients, or Hospital B gives poorer care? Well, there is a way that helps us with this at any rate, and that is what we call adjusted or stratified analysis. What we can do, for instance, if Hospital B has older patients, look at the old patients in A and B, level the playing field. Now we're just looking at old patients, and we look at the young patients in A and B. So now we have, Roman talked about confounding. We now have an unconfounded comparison with respect to age. Well, what if B has not only older patients, but more comorbidity? Well, we can look at the old with comorbidity, young with comorbidity, old no comorbidity, young no comorbidity, and in each case look at A versus B. So this is what a stratified or adjusted analysis does. It's a potential solution to this problem. So, what about outcomes monitoring? How is it typically done? Administrative databases. So these are big databases, observational studies, real-world observations. So it's not data collected for research, it's data collected for administrative purposes. And that can be in hospitals, outpatient facilities, or individual physicians. Now, are there any limitations to these databases? So there's been much written about it. Some of it was summarized in this study, which said administrative database research has unique characteristics that can risk biased results. What are these unique characteristics? To summarize it in a couple of words from this trial, the unique characteristics are that the databases are often inaccurate. In other words, you can't believe the data. All right, so point one, administrative databases, the data in those databases may not be accurate. Now I'm going to tell some stories about adjusted analysis, which I've told you, hospital B, 15% mortality, hospital A, 10%. We try to sort out whether it's the sicker patients in B or whether B really gives poorer care. And the next stories are about adjusted analysis. So, way back when we were doing open cholecystectomies instead of laparoscopic, some surgeons would take out the appendix even if it's not diseased in the course to prevent subsequent appendicitis. Is this a good or bad thing? Well, administrative data from my jurisdiction where I live and where many of the speakers live in Ontario looked at almost 8,000 cholecystectomies where the surgeon decided to take out the appendix. And close to 200,000, these administrative data, PJ was told you all about sample size, they have the advantage of big sample sizes. So almost 200,000 where they didn't take it out. And the question is, was it a good idea to take out these appendix or not? Well, good idea for preventing subsequent appendicitis, but are there other issues? So, the mortality with appendectomy was less than 3 in 1,000. The mortality in patients who didn't have the appendectomy was getting up toward 10 in 1,000. Odds ratio of 0.37. So Roman has told you that's a 63% reduction in odds and an impressively low p-value. Clearly, incidental appendectomy saves lives. It lowers mortality, right? You believe it? No? Why not? Okay. Well, you should in fact be skeptical because the issue isn't that it saves lives. The issue is that the people who received the incidental appendectomy weren't as sick. If it's a sick patient, look like they're in trouble, the surgeon's not going to stop to take out the appendix. Well, so we do this adjusted analysis I told you about. And what might we adjust for? As usual, unfortunately, the men do worse than the women with mortality almost over twice as much. Again, unfortunate as I get older, the old people do a lot worse than the younger people, a more than tenfold increase in mortality between those under 60 and those over 70. Comorbidity, as you would suspect, influences mortality. Again, a tenfold gradient in those with comorbidity and no comorbidity. And the more emergent the surgery, the more the mortality. When you do this adjusted analysis that controls for all these variables, the odds ratio becomes very close to 1.0, and we conclude that incidental appendectomy doesn't affect mortality. Does that end the story? Well, perhaps not. The reason is the adjustment may be inadequate. For instance, we classified people as no comorbidity or comorbidity. Well, that's obviously oversimplification. We can have a little bit of comorbidity, moderate amount, large. So what would the solution be? Some have suggested focus on the low-risk population. And if you focus on the low-risk population, the risk should be more homogeneous. So what about if you only do elective surgery in those under 70? Now the odds ratio is 2.65 and the p-value less than 0.05. Now the conclusion is incidental appendectomy kills. Bottom line, the way you do the analysis can affect what the results are. Another story, Coronary Drug Project, NEJM 1980. This was way back before we had statins, when we were experimenting with all sorts of other treatments to lower coronary artery events in individuals who had high cholesterol. And the intervention studied here were things like clofibrate, estrogen, thyroxine, nicotinic acid. So they compared a number of these treatments, about 1,100 in each drug group, 1,103 given clofibrate. Placebo was administered to close to 2,000 individuals. This trial used adherence by medication pill count. The mortality was a little bit lower in the clofibrate than placebo, but easily explained by chance, a p-value of 0.55. Well, what if you looked at compliance? In the clofibrate group, 357 patients had low compliance, less than 80%, and a 24.6% mortality. 708 patients had greater than 80% compliance, a 15% mortality. If you were just looking and doing the intuitive and attributing these events to whether you took or did not take clofibrate, you would say, A, the clofibrate works, a 39% relative risk reduction, and look at that p-value. That is an impressive p-value. Chance cannot explain these findings. What, however, if you looked at placebo group compliance? Those who didn't comply with placebo had a 28.2% mortality. Those who complied with placebo had a 15.1% mortality. Complying with placebo had an even bigger effect than complying with clofibrate, a 46% relative reduction. And have you ever seen a p-value more impressive than that p-value? Okay, so something's wrong here. We don't really believe that complying with placebo reduces mortality. So what if one did an adjusted analysis? Well, if you adjust the analysis, as they did, for 40 predictors of outcome, your ECG, the drugs, functional class, cholesterol, the adjusted mortality in placebo in those who did not comply went down from 28 to 25. The adjusted mortality in those who did comply went up from 15.1 to 16.4, but there's still a 36% relative risk reduction, still a very impressive p-value. It still looks like taking your placebo reduces your mortality. The adjustment helped, but the adjustment did not obliterate what is certainly a spurious or misleading apparent mortality reduction due to taking your placebo. So, next story. Next story is started in the state of New York. And many years ago, in terms of enhancing quality, the New York authorities decided to release the data on hospital mortality. And that recently started happening much more recently in our jurisdiction in Ontario. So you find out, if you go to hospital A, what your mortality would be after coronary artery bypass grafting versus B. And then they were even more daring. They started to release the data on mortality in individual surgeons. The result was an exodus of surgeons from New York State whose mortality looked like it was high. Well, what was the effect of this interesting quality assurance measure of releasing the mortality figures in hospitals and in surgeons? So in this particular study, they looked at statewide outcomes of coronary artery bypass grafting from 1989 to 1992. The crude mortality went from 3.5% to 2.8% approximately. When you did the adjustment, the difference was even bigger because over those 3 years, they started operating on sicker patients. So when you adjusted for the sickness of the patients, the reduction in mortality was even bigger than the crude reduction, a 41% decrease. The investigators who did this published a commentary in which their discussion said, quality improvement programs based on similar principles for other procedures and conditions should be undertaken. This is a good idea, telling everybody what the mortality is. Either the bad surgeons either leave, go somewhere else, and inflict their mortality on somebody else, or hopefully the hospitals buck up and the ones that aren't doing so well improve what they are doing. So seems like a great idea to be releasing this information. However, a Canadian, Bill Gali, who was then doing his postgraduate training in the United States, published in JAMA on math data from Massachusetts. In Massachusetts, they didn't give any feedback or systematic quality improvement. And he looked at the coronary artery bypass adjusted mortality, and again, adjusting for a whole bunch of variables, which is the approach, as I've told you, that tries to help get around problems of different illness. So, unadjusted mortality, 4.7 to 3.5. Again, they were operating on sicker patients. The adjusted mortality reduction is 35%. In other words, in Massachusetts, with none of these, you had the same reduction in mortality as you did in New York. And then he looked across the whole country. It didn't matter whether when you were in New York, Massachusetts, or the rest of the country. Everybody, whether they had these quality control measures or not, were seeing the same reduction in mortality. The reduction in mortality had nothing to do with the quality assurance measures of releasing the information. So, the bottom line here is, well, let's see if I've got my message through. Okay, now with what you've heard, what do you think about process versus outcome in terms of quality assurance? Who thinks that outcomes are the best way to do it? Who thinks that process might be better? All right, okay, good. So, if you are going to do the outcome monitoring for quality assurance, you'd better document the quality of your database. Yes, you should control for lots of confounders. Yes, you should look at very low risk subgroups. Yes, you should avoid before-after studies without concurrent control groups, because what happens, you may see a difference, but it might have nothing to do with your apparent quality control procedures. And even if you do all that, you should interpret the results with caution. Well, what's the alternative? The alternative is to monitor process. Randomized trials tell us what works. And I just give some examples from the general medical practice, which is my practice. So randomized trials tell us what to do, they tell us what works, and then what we need to do is monitor the process and find out if in giving our clinical care we are doing what the randomized trials tell us what to do. So we can then do observational studies. The observational studies don't look at the outcomes, but they look at whether eligible patients are getting the interventions. Then we can say, okay, if after myocardial infarction, there's a large door to stent time where people aren't getting their aspirin or they aren't being offered the other mortality reducing drugs, then we got a problem, and then we can intervene to improve our process. When you see report cards based on outcomes, which in many jurisdictions you will be seeing, you should report those with great caution. Yes, they use administrative databases which may have errors in them, substantial errors. They used adjusted analyses, which in many instances are inadequate to provide an accurate estimate of what is going on.